Welcome, everyone. Thank you for joining us this afternoon on a conversation around driving better outcomes, evidence, and local implementation of measurement-based care. I'll be one of our hosts today. My name is Jordan Feinwax. I work at Greenspace Health. As much as I've implemented measurement-based care across dozens of organizations working with Greenspace, I believe a lot of the voice will come today from Dr. Kathleen Kern. So Dr. Kern, I'll let you introduce yourself as well.
Great, thank you. Yeah, so I'm Kathleen Kern. I'm Chief Clinical Officer at OhioGuidestone. And for the last probably just over a year, been spearheading our measurement-based care initiative. So I'm excited to talk with you about that today.
Amazing. Well, I'm going to kick things off. Nothing like starting things with some rules just to remind people. We are a Zoom webinar, so everything is being recorded today. If you have to drop off for whatever reason or someone you know couldn't make it, we'll be sending that out afterwards as well. Everyone's phone lines and microphones are muted, but you can share your thoughts in the comment box throughout the session. I'll do my best to bring those up as we go along. You can submit questions via the Q&A box, and if someone's question looks really great to you, give it a thumbs up so we know that we can address it at the end of the session. We have about 15 or 20 minutes set aside near the end of the session to go through some of that Q&A. Also, there'll be some polls, like I mentioned throughout, so please, if you see something pop up on your screen, it is not spam. It is here as part of the webinar to engage you all and make sure we understand where you are at. Now, what are our objectives for today? My goal is to, first and foremost, do very little talking, be able to bring over what Dr. Kern has done over at OhioGuidestone, but really, we need to understand the why behind MBC. MBC is our basic measurement-based care. Where does it come from? How does it impact us? Learn those fundamentals as a group so that everyone is at the same baseline, and then really, for the bulk of it, gain an insight into OhioGuidestone's implementation journey, as well as their lessons learned and continued lesson learned as we go through our measurement-based care implementation. While I am not an expert, I have had the measurement-based care Kool-Aid a number of times. So what is it? Measurement-based care, here's where we're at. Organizations want outcome data. And measurement-based care really is the routine collection and use of client-reported progress measures throughout treatment to guide clinical decision-making. And where we sit today, we have a current state. We've had pre- and post measures done historically. Really, really manual process, trying to understand what happened at the beginning of treatment and what's happened at the end of treatment. Have we seen improvement? Have we seen a decrease? The idea behind measurement-based care is to not only increase those touch points, but understand that people aren't linear, understand that progress isn't linear, and that there may be fluctuations throughout. MBC is really that shift into using assessments throughout care, that greater depth of data on multiple different domains, and really an ability to change that trajectory, really an understanding of how can we incorporate measures into treatment plans and help our patients, clients, consumers succeed at the end of the day. What we like to break it down at Greenspace, again, not a clinician by trade, but we really like to focus on what we call our 4 Cs. It has to be consistent. If you think to the definition, routine really does mean routine at every instance, whether that's every session or every other session. That consistency allows us to track those changes over time much more effectively. They need to be customized. We need to understand what our clients, our patients, our consumers are going through and address their needs at the end of the day. What's really important, we need that clinician client visualization to understand, are we on track? Have we made changes? Have we made strides? And if we haven't, well, where do we go next? So really being in tune, the client and the clinician together, really important to visualize that data. We're in the era of 2025 data and AI. Let's make that really helpful for our clients and patients. And then finally, at the end of the day, it has to be collaborative. It is no longer a patient or a client against a clinician. It is the two of them together working towards a problem. It's that collaboration in, well, let's try something together. And you're probably sitting here wondering, Jordan, you said you're not a clinician. You said you've worked with measurement-based care implementation. So why you? Why are you here? Why is Greenspace here? And that's really who we are at the end of the day. We're here to help empower teams to implement measurement-based care and really transform the way that services are accessed, measured, and evaluated. And just a few, names and notes on screen here. We've worked with 500 plus organizations, over 20,000 clinicians, many of which at OhioGuidestone, and we've completed and seen over 5 million assessments on Greenspace to understand what really takes improvement and how do we actually translate it to overall outcomes and organizational improvement and quality at the end of the day. And this is why it matters. This is why measurement-based care matters. Organizations are increasingly seeing a need to improve and demonstrate outcomes, understand the clinical impact, and realistically, we've got tons of accrediting and reporting bodies, the Joint Commission, CARF, counties, you name it. Everyone wants to understand is what we are doing working. And I think this is a really great spot to pull up on screen here. Where are you with your implementation journey? Where are you with measurement-based care? I think that's a super fantastic way. Oops, that's not the right one. Nothing like a little tech challenge here. Let me just take a quick peek. Here we are, really just understanding, what extent measurement-based care is working to you. So feel free to add on here where you're at in terms of your implementation, if you've done it, where you've gone through, and so on. I think that's enough talking for me. Hopefully that gives us the basics of what measurement-based care is. But like I said, I am not the expert here. Dr. Kathleen Kern has been working alongside OhioGuidestone for quite some time and understands measurement-based care vastly more than I do. So I'm going to pass it into her very capable hands and let you take the reins here on your implementation journey.
Thanks, Jordan. So, and I will say, I think before we started this journey, I did think that I understood measurement-based care, but I think even back then I had it a little bit confused with the idea that we collect data on a regular basis and we use that data to see whether or not our clients are getting better. But we typically have done that in broad timeframes, like look at how someone's doing on depression now and then again in 3 months. And what's really different about measurement-based care is having very short measures that are done on a very quick turnaround every couple weeks, every month at the most, so that if we're moving in the wrong direction, we do have the opportunity to change it up. It really allows clinicians to be agile in their approach. And that to me has been the biggest difference. So today I want to start by talking a little bit about OhioGuidestone's journey down the path of measurement-based care. And I want to be clear, the guy on your screen is not doing a victory lap, right? We're not pretending to be at the finish line. And ultimately, I don't know if we ever will. I think it's a constantly evolving process. But what I want to do today is talk to you a little bit about our particular story in hopes that you might garner something from it that might be relevant or helpful to you on your own journey. So our story started probably in the spring of 2024, right before I joined OhioGuidestone. And really what happened was the leaders were trying to figure out, how do we do better care, right? How do we get better client outcomes? How do we get clients to the point where they're experiencing real relief from symptoms more effectively and maybe even quicker? And so, you look at all these different strategies. We do a lot of evidence-based practices. But what really happened is we look at the data and we see, wow, like when people do measurement-based care right, about 40% more improvement. You're more than 3 times more likely to have really clinically reliable change. So when we think about that on the wholesale and we think, wow, if we fundamentally change the way that we're interacting with clients, we could do so much better work. And that's kind of where it started. Now, for OhioGuidestone, the next step had to be kind of building a structure, right? Because we are an organization with 40 different sites across all of Ohio. upwards of 800 service providers or supervisors who are working with clients. So implementing a change this large in a structure that is this diverse in terms of, different areas of specialty, different services, different areas of the state, different boards to report to, it was challenging. So we started out by creating kind of the structure. We created a steering committee and an operational committee and an awareness committee and populated those with people from all over Ohio Guidestone, different disciplines, different areas of focus, so that as we went through the next phases, as we really tried to think through and answer those critical questions, like what kind of measures are we going to use? Who's going to be accountable? How are we going to implement? Are we going to send all our measures automatically, or are we going to ask service providers to implement them manually, asking those questions in session? So all of those questions had to be asked and answered in preparation for our plan. And the only way that we were able to do that was to really put together a multidisciplinary team where somebody could raise their hand and say, like, yeah, that's not really going to work for our adult recovery housing, right? And so getting enough people together to challenge the process obviously made it a little bit of a longer planning process, but I think ultimately helped us in terms of our long-term implementation. The other thing I'll say is those committees continue because, as I mentioned, we're not even close to done. And we're constantly looking at how do we improve what is not working for this particular program or what is not working in terms of this particular client set. So having that cohort of people who are really focused on the same thing that we're focused on, and really at all levels, our steering committee, kind of the ultimate decision makers, the operations really helping us to move from theory and training right into practice. So I feel like in retrospect, if we did things right, it's because we really did set up that structure on the front end. And we had a lot of those challenging conversations on the front end. We then put together our procedures and decided where we we're going to pilot measurement-based care and kind of what questions we wanted to have answered in that process. And throughout this whole journey, we've had a big focus on awareness, right? So recognizing that this is a big change for the organization, we didn't want anybody to be surprised. We didn't want anybody to say, wait a minute, I've never heard of this measurement-based care thing. So even as we are developing our plans and trying to understand how is this really going to work, we're simultaneously feeding out information across the organization, getting people curious, getting people talking. And that was all part of our phase 1 journey.
Dr. Kern, before we go to the next slide, I'm curious, being part of this implementation alongside you, those challenging conversations, have you seen a shift in people's openness to share those challenges in process and procedure compared to if you were to think a year ago when we first got started, knowing that we've made good on so many great initiatives and unblocking change? Have you seen people feel more comfortable sharing those challenges and frustration, or has it been pretty steady along the way?
No, I feel like as time has gone by and we've seen kind of the results of having those tough discussions, people are more willing to bring up potential challenges. And I think, at the time, it definitely feels like it elongates the process. At points, you're like, can't we just, come to a decision and get this thing moving? But ultimately, I think we've learned, all of us have learned, like it actually has helped to have people in the room who disagree, people in the room who speak up. And I think ultimately it's saved us time from not kind of going down one track and realizing later, like, oh no, that's never going to work for our school-based population or something like that. So yeah, I think it's had an impact. It continues to be a challenge. I think having different leaders in the room with different perspectives is the hard thing to do. And I'm not going to pretend it isn't, but I do think it's, at least in our case, it's helped us come together on more of a plan that has had less post-implementation surprises. The things that people predicted were going to be a little challenging, they didn't absolutely shock us because we'd had some conversations and been able to kind of remediate some of the challenges.
And to that guiding light of setting up this structure, again, we had our goals right from the start. We had goals for our steering committee, we had goals for our engagement committee, we had goals for our operations committee. And anytime things veered off, whenever it may be, we were able to point back, is what we're discussing helping us achieve one of those main items? Great, let's continue forward. And being able to, again, realign on what is important here, and what's something that can really take shape later. I'll pass it back over to you for the phase 2 or the phase 1.5 in our approach.
Thanks. So this is it. We had initially decided, like I said, we have 40 sites. We decided we wanted to pilot in just 2 of them, starting with only 50 service providers and 4 clinical leaders. And that was, I think, a really important decision as well, trying to figure out, where do we pilot? Who has clients that are representative of the greater organization? So we made the decision, and then we actually started, and I think this was an important learning piece for me anyway. We started the training only with the supervisors, and initially I'm like, really? We're gonna spend like 4 hours of training on 4 people? Ultimately, that had the best payoff that I could have ever expected, because really making sure that the supervisors were in a position to lead and to help their service providers as their service providers later came on board was unbelievably helpful. I cannot underestimate how much that stretched our ability to be helpful to people, in the moment of implementation with those who they already trust, and also being able to get those questions answered so quickly and not creating any kind of a bottleneck that would have resulted in people saying like, this is too big, this is too much, I don't want to do it. So having that supervisory training first, then training all of the other staff within that location. And then it says communication. I would say really a lot of what we did in those first 6 weeks is being present and listening, recognizing that the pilot group was doing us a favor by, being those early adopters and taking those lessons learned. And they had a lot of good lessons for us. They helped us really to shape our processes. They helped us to figure out what kind of supplemental information people needed, whether it was checklist or Jordan had done multiple really short 1-minute videos about how to use the tech in response to some of the questions they had. And that, I can't underestimate how helpful and powerful that was, because people weren't going to go back and watch an hour-long training that they had seen on a particular part of measurement-based care, but being able to pull up exactly what they needed, see it demonstrated, and do it. For us, that was hugely helpful and something we carried forward.
And Dr. Kern, I've got the context of implementing elsewhere. I think that's pretty apparent in so many organizations. The supervisor first training, they are our first lines of defense for our frontline workers, clinicians, behavioral health specialists. All of the questions go to those supervisors. So equipping them and making them feel heard, joining in their existing team meetings, like you said, listening really well to what they have going on. I think puts a nice bow on why we were able to learn and be successful. I'm curious, obviously I joined many of those different sessions, and for anyone out here, what would you say was the clinicians' feedback early on in this approach, when it comes to not necessarily the tech, but the transition from what they were doing before to what they're asked to be done now?
Yeah, so I think the biggest difference for our service providers was that we used to have clients and service providers kind of sitting together, completing outcomes, and sometimes outcomes that didn't necessarily feel 100% as meaningful to the client as we might like them to have felt. So I think the biggest difference was being able to have the opportunity for clients to complete this on their own. When they come in, we're able to kind of see the results, and also to see them in a way that really breaks down the actual symptoms. So instead of having these global ideas like you're depressed and now you're less depressed, our service providers are able to see like, okay, so you have a moderate level of depression, and I can see like in a snapshot, I can see the way it's showing up for you is sleep disturbance, appetite disturbance, lack of interest in doing things with the people you care about. Like it just equipped them, I think, to have different and probably more meaningful conversations because we weren't talking about like these big buckets of symptoms. We could really hone in on what it is the client is telling us is most important to them at the time.
I mean, that's the idea, right? It's patient reported and it's in a very specific time frame so that we're really understanding those multiple data points and can see those transitions. Thinking to some of the challenges, I think it's a great time to ask the group here, what do you all think would be your most significant challenges, whether you've already implemented a measurement-based care process or solution? I'm going to instate my relaunch the poll over here, just to see on screen, is it the people? Is it the technology? Is it the training? Is it the process? Already seeing some answers flow on screen here. Dr. Kern, seems like a lot of people right in this early going are worried about their people. And I'm curious, how does that resonate with you in the early goings and now that we've done a little bit more on our organizational launch, which we'll talk about shortly.
I think that resonates quite well. I feel like people often are challenging to shift in their attitudes and to shift in their behaviors. And actually, we had more success shifting people in their behaviors, getting them to complete the measures, to talk about the measures. I think actually shifting the attitudes and helping people understand, like this is qualitatively different than collecting outcomes every quarter. Like it really is about conversations, and it really is about, even if the measure was completed 3 weeks ago, take a peek at it, use it to inform the work that you're doing. And I think that attitudinal shift that says, this is absolutely a gift for me to have so that I can improve my care. That's one we still are working on. And I don't imagine that it happens overnight. It's kind of one of those things that I think the more people do it, the more they see the value. But we had to kind of get them first to have the exposure so that they had the opportunity to be reinforced and see the real true value it has.
And a little bit of a question that self-serving here, people are at the core of, well, their challenges with the technology and their challenges with training and challenges with process. But I think from what I understand, what works so well at OhioGuidestone, really, again, identifying who our people are, getting everyone on board with the different pieces. Technology is one part of the training, but how do we as an organization make this focus on quality, drive towards those organizational goals? I think that's really what made this so far so good, knock on wood, successful in our early goings here.
Yeah, and I will say one thing about that is around the training piece, I think, that was one of the areas where in the steering committee we were kind of back and forth trying to figure out like when's the right time to train staff. So we had like 4 modules we wanted them to get through. What is measurement-based care, the measures for adults, the measures for children, and then the actual practical use of Greenspace, and trying to figure out like when's the exact right time to have people trained so that they retain this information, they know it before the client starts completing measures that are coming into the system. That was kind of a challenge. And I think for us, I think we had the best potential solution in terms of creating like on-demand trainings that would allow for service providers when we went to full implementation to train at their own pace and like when they felt like they were ready. But I can
And
talk
I'll
about
say
other challenges too.
and I'll say, from this side, as we go to talking about some of those challenges as well, every organization is different. Some have resources aplenty in terms of training and what's worked in the past, and on-demand take-home assignments embedded into someone's workflow that they need to adhere to every month or every 2 months because it's part of the culture. But sometimes simpler workflows work as well. I think the key is the consistency, right? Having updates, reminders, refreshers. That's what we continue to work on and work through, whether it's working on these different challenges. Really, really important to understand how do we keep our staff engaged throughout the process, and make them feel heard as well. So, Dr. Kern, I'll pass it to you on, we asked the group what their challenges were, but what did we see at Ohio Guidestone?
Yeah, so I think after that pilot program, we had some challenges that we expected to see, and those bore out. And then some that just helped us to think through, this is not a big problem for our small scale, but when we go and implement to the full organization, it's going to be a challenge. So the first one that comes up, we decided to do a PHQ-9 with adults, and I'm guessing a lot of people on this call know what that is, but it's a basic depression measure, really short, very symptom-based, super helpful. Question 9 on that does ask if a client is experiencing thoughts of suicide. So we knew up front that we needed a plan to make sure that if a client said yes, they were going to get immediate guidance to call 988. So no matter when they fill out their measure, they get that guidance immediately. But we also knew that we wanted the clinician involved with that client to be reaching out and doing a suicide screening so that they could determine, is this somebody who has thoughts alone, who is less risky, or is this somebody who actually has thoughts with a method and intent where we might need to have a more assertive intervention to make sure that client stayed safe? So we worked through the process of how to do that on the pilot level. And I think got pretty good at it. But one of the things that we realized is it was kind of a tracking nightmare to, when we identified clients who had been flagged, making sure that they had been screened and then having to go back after you asked people to do it to make sure it was actually done. So we were able to work out a technological solution where we could get the results from Greenspace. We could see which clients had screened or flagged on that PHQ-9. And we could see from our electronic health record, did they or didn't they get screened? And that was kind of a necessary thing that had to be in place before we could go to wide scale implementation so that we were prepared to respond to what our clients were telling us. Technology adoption, I would say, I would say this if Jordan wasn't on the call, but that was not as big of an issue for us because I think Greenspace and specifically Jordan did a phenomenal job of being receptive, providing the initial training, being receptive, offering office hours, offering little videos. So I think we certainly had people who were a little bit concerned about technology in general, and needed the soft touch of their supervisors to kind of get used to it. But I don't think we ran into huge numbers of technological challenges from the user perspective, that weren't pretty quickly remedied. I won't say easily, but we were able to remedy those relatively quickly. And I think, again, part of the experience that Jordan had in working with other organizations allowed him to break down that information in a way that we needed it to overcome any challenges our service providers were having. And the third one, again, is adopting the philosophy, right? So I think we've got people to the point where they're completing measures, which I'm excited about. I think there's still room to grow in terms of people doing it, not because it's the thing that has to be done, but because it's the thing that helps them and their clients. And again, I think that is a longer term change that we're only going to see with continued efforts to keep doing measurement-based care, keep giving our service providers the opportunity to experience the benefits.
And on that last note, Dr. Kern, I wonder if you can speak to, I know it's not on our slide here, but some of the ongoing pieces that have been happening at Ohio Guidestone, whether in supervisor meetings, in email delivery or notifications across the organization. I know there was a lot of work put into, it's not you learn MBC, measurement-based care, and that's it. You have to experience it, but also short and quick items, really helpful to having people turn their heads and look at and say, no, this is something I should be doing.
Mm-hmm. Yeah, so we put together an awareness campaign where we would even send out little scenarios about what might be going on with the client at the beginning of the week, and then at the end of the week, provide some information about one potential way that you could respond if a client had the findings that were shared with the group in the beginning of the week. So more specifically, like we would send out a graph and a little scenario and then talk about by the end of the week we want supervisors to have communicated that with their staff. And then we come in at the end of the week with hopefully just another option for how measurement-based care could be utilized in that particular situation. So a lot of that awareness campaign that we did very early on to make sure that nobody was surprised, we wanted to continue it such that as people are actually now in Greenspace and using the measures and coming up with questions, that there would be some kind of built-in forum where it became, part of the way we do work in supervision is to pull in the information that we're seeing in measurement-based care.
And again, sitting on this side, seeing so many implementations, I think that super tactical, here's an example, here's how I as a clinician may think about it, obviously open to other opportunities. I think that gives clinicians that tool to say, hey, I've seen this before. Where did I see this before? I've seen those trend lines going in one direction. How do I turn this now into working with my own client and use it effectively? And I think a lot of organizations forget that clinicians are busy and they've got 7 to 8 hours of clinical time a day with clients, hopefully filling their calendars to really make it short pieces of information and bite-sized really helps them put it into play and use it day in, day out.
Yeah. And I would say we kind of developed a little bit of a menu of frequently asked questions, and we put out the frequently asked questions, but at the same time, we kept getting the same questions over and over. So we ended up using that document to just reply to emails, as opposed to asking somebody to go the extra step. It was our job, I think, as an implementation team to put the information in the hands of the people when they were asking for it so that they didn't just put it away and say, I'm not going to do this, or I'll worry about it later. So we've talked about the pilot phase. We've talked about lessons learned. What I would say is moving from 50 to just under 800 staff was our training and scaling piece, where we really had to think about, as I had mentioned, in terms of the PHQ-9, what are the things that worked okay on the pilot, but when we think about making them, available to 800 service providers, this is not going to work. So we worked through what we had learned. We also looked at our key performance indicators and tried to right size those based on what we had learned from the early adopters. And I think that was a really important piece. Jordan and Greenspace had given us some good guidelines, but I think seeing what the early adopter or the pilot group was able to do, it really helped us make meaningful kind of key performance indicators. And those became really, really important. I talked before about the structure, right? Having the steering committee and operations committee. We really wanted to use those key performance indicators to communicate how things were going at multiple levels, like sending it to supervisors, discussing it in supervisory teams, talking about it at senior leadership, talking about it at the steering committee to try to figure out, like, to what degree is this a small kind of regional challenge? To what degree are we seeing supervisors or service providers in one area really killing it? And how do we pull that in? So we wanted to make sure that when we were scaling, we were really thoughtful about thinking, what is it that we're going to want to track and measure that will then help us to make decisions to continue to improve implementation? So developing those KPIs as part of the following the pilot was really important. As I mentioned already, making sure that the training was available on demand so that people could take it when they needed it. And probably what happened more often is people might have taken it and also been, listening to an audiobook or maybe not fully attending. And then later on, once they had clients and they're actually seeing this in the real world, they would go back and review those pieces or parts that they really needed to do in order to do implementation well. Again, we offered the supervisors training before we made it available to the rest of the organization service providers, using some checklists and resources that we had learned were going to be important based on what we had in the pilot group. And again, we had to educate clients, sending out things to show them what it would look like when they got the message on their phone so that they would know this isn't spam. Everything that got sent out was sent from OhioGuidestone. So we had some ability for clients to say like, oh, I know that name and not throw it away, but giving the information up front about what it would look like and what would be expected of them, like what we'd like them to do when they get it, I think helped a lot in terms of, reducing surprise and getting our clients to buy in earlier in the process.
And Dr. Kern, the one thing that jumps out to me about this slide in general and the training and scaling is details, detail, details. At every meeting in the engagement group, the operations group, the steering committee is, where else can this be shared? What else needs to be updated? I point at the supervisor support here, even down to the checklist of asking your clinicians, asking your supervisees, about Greenspace, reminding them, about measurement-based care and reminding them how to incorporate it, down to the client education materials that marketing had a hand in, and one-pagers and bulletins and whatever it may be. The only reason these small details come up is, again, back to that overarching, we set up our pillars and our steering committee and our committees to understand and incorporate all of these items for a successful launch. And, I over to you, we had a pretty widespread launch. It wasn't small potatoes, 11,000 clients. What did this look like? And what are we in the weeds of right now?
Yeah, I will say, so June 30th was, I don't know, from my perspective, a little bit of a stressful day, just seeing the numbers jump and just realizing like, okay, this is really happening, and questioning, are we really ready? Are people going to know how to respond? So yeah, I mean, we had 11,000 of our current clients dropped into Greenspace, sent metrics, all within the span of 1 or 2 days. And right away, we began kind of looking at those KPIs, looking at the number of clients who were completing measures, looking at the number of providers who were signing on to Greenspace. And we wanted to really get a look from the jump to see like, okay, is it working? We can see that 11,000 are going out. Can we see that any are being completed? So we had a nice eye on it. And it, from my perspective, the Greenspace platform makes it pretty easy to look and see. You can even see which clients are flagging. So it was pretty easy to kind of keep an eye on how this was moving forward. We use the structure that we have, right? Like we use the leadership support to kind of review these metrics. We joined supervisory meetings whenever we could. And one of the things that I think was probably the most helpful is we took some of our champions from our pilot to join in supervisory meetings with the kind of organizational adopters, the people who came in all at once. And I think hearing from supervisors who had been through this, I think that was incredibly helpful. And they might have been saying the same words that like we were saying, but I think hearing it from someone who had, lived it, communicated it to their own service providing staff, I think that actually paid volumes. We did a lot of work to identify who's doing this well. And again, that's relatively easy to see in our platform. You can quickly see how many clients have completed the measure based on each service provider. So we could see, which service providers pretty early on had, first 10% and then more than half of their caseload. So we did some celebrating of their accomplishments and really just tried to make it clear that these service providers, they are amazing in what they've done, but they're also quite similar to the rest of the service providers. They don't, they don't have smaller caseloads, they don't have more time, and yet they're able to accomplish this. And we wanted to hold that up as an example. Across this whole implementation, I can't say enough about the role of supervisors. I mean, supervisors who are supporting, who are championing, who are identifying challenges and bringing it up through the processes to make sure they're remedied. Like having those people who are already trusted by the service providers made all the difference in the world, and making sure that they really saw the value on the front end, so that they are willing to say, hey, I'm not really sure if this is supposed to be happening, but here's a problem. And I feel like they're a tremendous conduit of information, both when we want to share out information and say, hey, in this particular site, we're seeing less clients using measurement-based care. They can then strategize with the people who are doing the work. On the other hand, they can also gather the information. We did a survey to say, if anything's getting in the way of your implementation of measurement-based care, tell us what it is. And I think for me, one of the things that felt kind of good about that is, number one, there weren't too many obstacles that were really getting in the way. And number two, they weren't a surprise. Like the service providers, the supervisors had told us, the service providers told the supervisor, and the supervisor are communicating these things to us. So it kind of reinforced that we have a structure in place where when people do run up against an obstacle, we're able to overcome it with relative ease. And I'll give you an example of that. We have a youth residential program, and one of the measures we had chosen for youth wasn't a particularly good fit for that program. So, we get feedback that the measure doesn't really fit this particular program, and we were able to modify that and change it to a more trauma-specific measure. But those are the kind of things that could kill the implementation, right? If they were left silently stewing about this measure is not meaningful, it's not helping my clients, our buy-in would have been diminished so quickly. But the fact that supervisors are on it, they're sharing the information, and then collectively we can figure out solutions, I think it does set us up to be able to address the problems that emerge. And I'm not going to pretend we're addressing every problem, and this is certainly not a perfect implementation. And I can tell you it's felt hard and challenging at times just to work through the level of details and to wonder if you've forgotten something. But I think to go from, nobody using measurement-based care to large numbers of our staff using measurement-based care, to me feels like where we wanted to be at this stage in the game.
And I think that's really where you are now. We've got numbers in terms of completion, but it's about, well, what next? Like, how do we take this to the next level when it comes to measurement-based care, feedback informed care, however you want to flip it? I mean, the numbers speak for themselves here, Dr. Kern.
You can call me that. Yeah, I mean, this aligns with our first quarter goals, right? So initially, we just wanted to make sure people are using it. We wanted to make sure that at least 50% of our service providers are signing in, 50% of our clients are using it. So we are kind of meeting our own key performance indicator for that, which is where we wanted to be right now, and something I feel like we can really celebrate. It is the beginning, though. It's definitely not the end. So as we look ahead to the next phase, really, we want to be moving from celebrating the fact that people are using it to actually using the information that it's providing so that we can continue to improve client care. And I mean that in two ways, like not just so that that service provider can get the information they need to shift gears if necessary, but also so that we organizationally can look at things and say like, oh, wow, when clients have anxiety, we are absolutely killing it. We're seeing great results, but in this small cohort of older adults, maybe that's not the case. And what could we do to better support that particular population of clients? What kind of training or what else do we need to do? We really want to get to the point where organizationally, just like a client and a service provider use measurement-based care together to figure out, are we moving in the right direction? We want to be able to use it from an organizational perspective to say, we're doing all this care. Are we moving in the right direction, or do we have to shift it up? Ultimately, we want to use that in terms of closing our quality gaps. And part of the way that we are structured to do that is just to identify where we're having challenges and bring people together, again, multidisciplinary team, to try to figure out what specifically could we do to, change the trajectory or shift a particular outcome once we have those outcomes in place. We do want to expand measures so that they better align with diagnosis. And I gave you the example of residential care. It's something that is taking a lot of work and a lot of energy just to try to figure out how do we kind of keep track of that and make sure that that we're not sending out too many measures to make meaning of, because we want it to be individualized, but we also want to be able to learn organizationally from it. And ultimately, we want to be able to use this data to demonstrate, like, yes, we are worthy of board funding or whatever kind of funding because we're doing care that helps clients.
I think there's so much to unpack there. But I am looking at the clock and I want to get to some of our lovely Q&A. Before we do that, Dr. Kern, looking ahead with all of these different pieces, what is one piece of advice you would give yourself or someone who is either starting their measurement-based care journey or looking to get started completely fresh? It hasn't even been a thought of their mind until today.
I honestly think, from my perspective, multidisciplinary groups that will help to plan in a way that makes it more complicated on the front end. Like, honestly, I feel like having enough people at the table who are going to say, that's not going to work with this, or this doesn't work for that reason, and being able to work through, as many of those challenges as you can on the front end. That's the advice I would give. And I think we will do the same thing as we talk about expanding measure sets and trying to figure out how do we do that in a way that balances a client's individual needs and our ability to need to aggregate data from multiple clients taking the same measure so that we can make that systemic change that we need. And, nobody right now has the perfect answer. So I think it's going to be another one that requires that wrestling and figuring out how do we make this work? How do we test it? And then how do we modify it if what we've chosen is not the right answer?
Back to the old drawing board of a pro-con table. Hopefully pros outweigh the cons. And if it doesn't, well, let's see what happens next afterwards.
Yeah.
Amazing. Well, I think it's a great time to just talk through. There's been a few questions chattering, so please, for others, enter them into the chat, into the question and answer on your screen. I'm going to pop a few up here, Dr. Kern, for you to answer. We'll go in order here as we go along. Ritu asked, what type of metrics did you implement? And I believe this came up during your KPI talk on, we refreshed some of our KPIs. So, what were some of those key indicators that you looked at beyond, I think you already mentioned client completion and clinician engagement?
Yeah, so as I mentioned, a big piece of our work had been around the process of identifying and responding to clients who had flagged on the PHQ-9 that they had risk. So one metric that we have is around how quickly after someone flags on a PHQ-9, we are able to provide that screening, the subsequent 6 questions from the Columbia to discern real level of risk. We're looking at averages around that and then able to kind of compare it across the different sites. One of the things I will say, and this maybe is another lesson learned, is I initially had like a laundry list of KPIs that I really wanted to know this and this and this and this and this. And I think really keeping it simple, because right now we're really focused on, please have clients use this, please use it yourself, because that's the only way you're going to become a true believer is when you have that experience. And please keep clients safe. So we did keep the key performance metrics to a minimum. And I think that bodes well for our ability to actually make change when we see them moving in a direction that is different than where we want them to be.
We can all come with the laundry list, and we'll get there eventually. There's plenty more we can uncover, but like you said, to translate it down to the supervisors, to the frontline staff, the clinicians, the workers, really needs to be as simple as possible so everyone knows what's expected of them. Michelle has two questions. We'll start with the first one, and I'll see where you take this. Other than the PHQ-9 and the Columbia Suicide Screen, what other screens are you using?
So just to be clear, the Columbia screen we're not doing in Greenspace. We wanted to make sure that we were doing that individually with clients and that we had the ability to escalate it to an assessment if necessary. So we do that either via telehealth or by connecting with the client. But I think your question is more around like what kind of what measures are we using in Greenspace? And with the adults, we use the PHQ-9, the GAD-7, and one of the measures I like very much, the WSAS. And part of the reason is in our planning phase, when I looked through all of the diagnoses that had been all of the clients and saw what diagnoses they've had over the last couple of years. The two that kind of rose to the surface for adults were anxiety, depression, trauma as part of the underlying anxiety. And we recognize the GAD-7 is relatively sensitive to pick up even changes in trauma care. So that's kind of where we started. We wanted also that functioning in adults. And like I said, I love the WSAS because it is measuring the degree to which somebody's behavioral health symptoms interfere with who they love, what they're doing, their work, their love, their study, their home. It just asks 5 quick questions. And I think it's so much more targeted and allows for us to intervene better. Like there have been some functioning measures that are asking about, 10,000 questions about how you're functioning in all these different ways, many of them that are disconnected from their behavioral health concerns, and many of them that we can't do that much about. So limiting that to just questions around how much is your functioning? How much is the fact that you have this anxiety or this depression or this trauma? How much is it getting in the way of your day to day? On the use side, when we aggregated all of the diagnoses, we saw really a combination of internalizing and externalizing. So, we had a cohort of kids with anxiety, of course, depressive symptoms, also ADHD, oppositional, defiant disorder. So we chose the pediatric symptom checklist, which is the one measure that kind of was short enough and integrated both the internalizing and externalizing. And for us, a really important piece of whatever screening measures we were going to use, we wanted there to be an analogous version so that we can have those therapeutic conversations where the parent answers one way and the teenager answers a different way, and we can kind of figure out or help the parent and the child with the connection that they need to have true healing. So that was a piece for us, and part of the reason we chose the pediatric symptom checklist. So everybody under 18 gets a pediatric symptom checklist to their parents. If they're 12 or older, they also do their own. And the same is true on the functioning side. So there's a version of the WSAS that goes to every parent talking about their child. And then for the adolescents, they give us their input as well. The only other measure that I'll reference here is that we utilize the brief addiction monitor for our clients who are in addiction services. And that's been really helpful. I love that measure because it looks at risk factors and protective factors as well as use. And for anybody who's done any work in the space, usually the risk factors are going up before the relapse ever happens. So it's a nice measure to kind of keep a clinician's perspective on when risk is evolving even before a relapse. And then on the residential side, we're using the CATS, which is strictly a measure of trauma, adverse childhood experiences that a client has had in their lifetime, and the degree to which that's manifesting in their behavior day to day. So I will say choosing measures sounded to me like a pretty easy task. but thinking about those that are going to be relevant and those that are going to be short, right? Because clients aren't going to complete. We used to use the ACEBA to measure outcomes, and it had 100 some questions, and there's just no way that you're going to be able to get clients to complete that and like at a cadence that will allow you to really do real measurement-based care. So we had to choose short, meaningful measures. And these are what we chose for now. We might shift it up next year, right? Depending on what we learn.
Yeah, I think that's a great way to look at it. Always evolving. You said that earlier, right? We're taking our information and we're growing because we're never done. We're never truly done implementing. Dr. Kern, with 1 minute or less to answer, just on the process, how and when are screens completed? During session, on a tablet, what's the process there? Just a quick overview.
The vast majority of our clients get their measures automatically through text. And then it is every service provider who is working with that client's responsibility to click on the measure before they start seeing. And if it's been as much as a month since the last time the client had completed it, if they're going out every month, the client might not have completed it, then they're responsible for doing it during that visit. So again, it's a work in progress. We might change the cadence, make it shorter intervals at some point, but starting at monthly intervals seemed like the right middle ground.
Great. And it'll always work to be done there too, to make things simpler and easier for our clients and our clinicians. Dr. Kern, obviously we want to thank everyone who's participating today. What message do you want to leave people with, coming out of this webinar on outcome measures, and where should they look to next?
For those people who are interested in doing client care better, getting better outcomes, I don't think there's a better strategy than measurement-based care. And I guess the only thing that I would say is, when joining this organization and knowing this decision had been made and knowing the size and the complexity of the organization, I thought, I don't know how I'm going to do this. Honestly, like it felt too big. And so I guess I just want people to know that it's definitely possible. It really is just it's about creating the structure and paying attention to the details. And it's absolutely, absolutely able to get it done.
That's awesome. Well, thank you so much, Dr. Kern. Appreciate your time, and appreciate everyone else on the webinar today. If you weren't able to join the whole time or wanted to refer back, we'll be sending out a recording. And obviously there's Dr. Kern's email for you to be able to reach out to. Otherwise, we hope you have a fantastic rest of your week. Hopefully the sun keeps popping out, and we'll see you all very soon.
Thank you, everyone.
Thanks, everyone. Take care.
Bye.